Hello everyone and welcome. I hope you can hear me. Thanks very much for joining us for this, our sixth and final session of this Global Health Summit. I can see on my screen that we've been joined by some of our great invited speakers. The subject for this session is closely linked, focused tightly on COVID. Are we, despite vaccines, going to have to learn to live with it? The headline is, can we learn to live with it? But this conversation, I hope, is also going to include the question, are we really going to have to? I mean, we've seen from the slides which we were playing just beforehand, thank you very much, Luke, for them, that life is already changing in certain important respects. We want all of us, most of us, I think, for it to go back to normal, at least in most respects. But it isn't. Today, we've just learned that Glastonbury, the festival, has been cancelled for the second year in a row. I couldn't help noticing that France has just cancelled the entire ski season. I don't know, Maurizio, if that's going to be the same in Italy. But quite apart from the fun that a lot of people will forego, that's a giant sector of the economy that's been put on ice almost literally for another 4 months. Yesterday, the new president imposed a new federal mask mandate in the States, in federal lands and buildings. So life is changing in so many different ways. And the question is, are we going to have to live with many of these changes because of COVID? So more specifically, we're going to be talking about vaccines and whether they're a get out of jail free card in a sense, variants to the virus and whether they're going to limit the efficacy of vaccines. And if broadly we do have to learn to live with this virus, then inside and outside hospitals, how are we going to do it? How has treatment changed? What have we learned in terms of treatment, especially in intensive care, but also outside the aspects of the pandemic that we've all had to learn to live with? Are they here to stay? We've got some great guests, I say, who I'll introduce as we get to them. But please, everybody, remember, if you've still got the energy and did take Liz's advice to have a cup of tea and a biscuit. I love the way she doesn't even grant us a lunch. Pitch in the chat, and we will do our best to pay attention. I'd like first, if I can, to come to Dr. Charlie Weller, who's head of vaccines at the Wellcome Trust. And let me just start by putting the sunny point of view. And this is very much a layperson's point of view, not a specialist's. Vaccines are finally here. Yes, there'll be some hiccups with the rollout. There'll be some inequities globally. But they're going to crush this thing, aren't they? Surely, ultimately, after the teething problems, they are going to enable us to get back to normal. What's wrong with that view?
Hi, Giles, and hi, everyone. So, it's what everyone's hoping for, to get back to normal. And then if I just start by, explaining where we are with vaccines. So we've got 3 vaccines in the UK that have been given emergency use, and these are rolling out at the moment. And we've also got, in the US, 2 vaccines have been licensed, and we've also got WHO licensing vaccines. And we've got Novavax and J&J vaccines and many other vaccines which are in late stage clinical trials. So there are more coming. But as of today, we've got, I think there's been more than 40 million doses which have been given to people in high-risk groups and healthcare workers around the world. And this is mainly focused in high-income countries. And we heard on Monday from the Director General Tedros at WHO that just 25 doses have been given in one of the lowest income countries. Not 25 million, not 25,000, but 25 doses. So while 40 million is staggering and amazing from a high-income country country perspective, we really must ensure that vaccines are available everywhere. And wherever we are in the world, there are challenges. And the job is far from done. Just because we've got vaccines doesn't mean we have vaccination. And we really, as a world, need to kind of realize what this logistical challenge involves, the challenge around manufacturing, delivering and rolling out the vaccines to every country. And we've never attempted to do this in our lifetimes at this pace with the number of vaccines we're trying to do, the number of doses we're trying to do now. And so just to put this into perspective, we need billions of doses. And currently all licensed vaccines, those three main ones I was talking about, they require 2 doses, which means that 2 billion doses protects 1 billion people. And we needed a variety of approaches to develop vaccines that work for a diverse range of people, different ages, different ethnicities, people with different underlying health conditions in a wide range of settings all around the world. So we do need that range, and that's why we do need continued investment, not just in the manufacture, but in the development of new vaccines. And it's vital that this continues this year. And as well as the supply, even when we have supply, delivering them can be challenging as well. All the vaccines that are licensed, they need 2 doses. This requires people to come back for a second dose. That might not sound like a big issue maybe in the UK when there are healthcare centres and doctors and these vaccination centres
except that it's already turning out to be a big issue in the UK.
Okay, it is all I'm not saying it's straightforward, but it is potentially more straightforward than it could be in a very hot climate with very rural settings, very remote settings. So there are different challenges around the world. And just thinking about the vaccines that we have, the Pfizer and Moderna vaccines need cold storage. Pfizer needs very, very cold storage, ultra cold, whereas the Moderna needs -20, which is the freezer you have in your kitchen. Most vaccines and healthcare centres and settings are set up for vaccines being given from fridges, which is just your normal fridge that you'd have at home. And therefore, anything that's different to this is going to be a challenge, especially at the speed and the scale that we're trying to do this. Luckily, the AstraZeneca vaccine can be stored in the fridge, so there is an advantage for delivery, especially in lower middle income countries. And the other sorry, Giles, did you?
No, go ahead. I don't want to interrupt.
No, I was just thinking, we've heard over the last month, and I think where we are now with the new variants, what does this really mean for the vaccines that we have available? I think everyone's wondering what this means. So there are 2 variants we've heard a lot about. The one that was identified in the UK, the B117, and that one that was identified in South Africa, B1351, and more recently a 3rd one in Brazil. It's really having a profound and devastating impact as we're seeing here, but all around the world, causing increased transmission, deaths, and leaving the health systems really on the brink. These variants really are inevitable. And as there are more infections, this puts more pressure on the virus to replicate and mutate, and that's normal. But at this moment in time, there's no evidence that the vaccines we have will be ineffective in preventing illness from the 2 strains or even 3 strains. But we do need to keep an eye on these, and we do need to understand more and more through research. But one of the things to think about is if we continue vaccinating only people in high-income countries while allowing virus to be to spread and continue to spread unchecked in other parts of the world, new variants will emerge. The more people that this virus passes through, the more it will continue to mutate. And then it is possible that the vaccines and treatments may not work against future variants. And that puts every country at risk and every person at risk. It hasn't happened yet, but it is a real concern, and why we need to fairly distribute vaccines around the world and have that fair allocations in rich and poor countries alike.
Thank you so much. Now, Professor Robert Dingwall is making the point in the chat that I would like to come back to, and I will give you a chance in a second. But before we go on, I wanted to ask on a technical point, is it the case that you vaccine specialists are reasonably confident that when the time comes, if it does, to tweak vaccines to take account of new variants, that is a relatively straightforward matter?
Yeah, we have seen such advances in vaccine development this year. It was unheard of before this year that we could develop a vaccine within a year, and we've done that. So it is still really ambitious to try and change vaccines and develop a new vaccine within, I've heard certain time spans like 6 weeks or 3 months. That's really ambitious, but it is more achievable with the new technologies we've got with mRNA vaccines. And if we think about what else we've got, what other vaccinations we've got around, if we think about seasonal influenza vaccines, we've already moved to a place to manage influenza, and we are able to, we've got a system in place where we can relatively quickly develop new vaccines to new strains of influenza. So we have got a system which we can build on and adapt.
And what's the regulatory rule there? If you adapt a vaccine, do you have to send it back through trials?
And this is what still needs to be worked out for influenza. There are criteria by which the regulators, we know what we need from the regulators. For coronavirus, we don't yet. We're still learning a huge amount about this virus and the new variants. So we're not sure what the regulators will need, but that's a conversation that is ongoing, will need to be had. We don't know yet whether we need to develop new vaccines, but we need to be prepared and have things in place for if that eventuality occurs.
Okay, great. Thank you. Professor Dingwall, I was going to come to you a little bit later to ask your view on sort of life in the street, as it were. But since you've said in the chat that you regard vaccination as primarily a social science problem rather than a biomedical science problem, can you sort of tell us now a bit more what you mean about that? By that?
Well, it's really just to say that the successful management of this pandemic requires a much more interdisciplinary approach than I think it may have had up to this point. And vaccination, and I thought it was a very helpful distinction that Charlie drew between vaccines and vaccination. And vaccine development is clearly primarily a topic for a cluster of the biomedical sciences. I think there may be things that social scientists can contribute in their understanding of the processes of innovation and discovery, issues about management and leadership in laboratories and so on, which are underexploited in that area. But once the vaccine leaves the lab and gets out into the wild, it's really transferring from the domain of biomedicine primarily into the domain of the social sciences. You're trying to understand the chain of social connections that take the vaccine from the lab to the arms or whatever part of the anatomy it's appropriately injected into of the recipients. And that's a process that goes on in society. As we understand how the chains, the organizational chains, the regulatory chains that form, as we understand about processes of hesitancy and resistance in the target populations, and what it takes to persuade people to accept a vaccine. It's the classic thing: you can take a horse to water, but you cannot make it drink. And all of those things will require the intervention and collaboration with the social sciences. It was very distinctive when the WHO evaluation of its own efforts to control Ebola in West Africa pointed to the biggest failing of that outbreak. Was the failure to get an appropriate integration of the biomedical and social sciences in the control strategy. I think it's really important that we don't make the same mistake over again by, in a sense, sort of producing a vaccine, handing it over and saying, okay, guys, get on with it. Or even worse, saying, well, frankly, we've done all this stuff in the lab and getting it to the people is just an extension of all the things we've done in the lab.
Right.
Because it doesn't work that way. Look, come back to me when when it's appropriate. Yeah.
Sure, that's an important point and point taken. I should, by the way, have introduced Professor Dingwall properly. He's a sociologist at the Nottingham Trent University and has been an advisor to the UK government over the course of the pandemic. Before we leave vaccines behind as a biomedical problem, I wanted to bring in Professor Maurizio Ciccone, who's very kindly joining us from Milan, I believe. Thank you so much. assuming we have time, I want to get back to your sort of core competence of ICU treatment and how that has changed. But you tweeted, I think, this morning on the subject of variants. So let's start there. Did I have you right that you tweeted, in most countries, we are not searching enough for new variants now? How worried are you about new variants as a mechanism for bypassing everything that we've put in place to control this virus?
So I think the worry that we have is that if we don't search, if we don't start to search for something, we're not going to find it. And if you remember, about 12 months ago in Europe, we didn't think that we had a problem with COVID. We had a few cases that we were monitoring. The risk criteria were mainly traveling from China or having been in close contact with somebody with SARS-CoV-2 in the previous 2 weeks. That was roughly the same everywhere in Europe. But what we know after that is that clearly the virus had been circulating for a while. And you can see a parallel here. The UK has been sequencing quite a lot, and I think other countries like Denmark are doing quite well on that. However, if you see the number of cases that we are isolating in Europe and the number of sequences that you see, I do think that is still low to be able to understand what is the prevalence of a new variant and to understand if it's going to become predominant in other parts of Europe. It doesn't change what we do in terms of prevention, because we have to keep the same level of attention. However, we've seen from the colleagues from the UK how fast this could be. And therefore, what we've learned with this virus is that when you wait for the crisis to reach hospital level, you've lost 2-3 weeks to put more restrictive measures in place. And I think to know that we have a faster variant around that is becoming more prevalent should prompt faster decisions at government level.
While we're on sequencing and the business of searching for these, how does that work? What is the optimum situation for sequencing? You said, and others, that the UK isn't bad at this. What is required to sample, to take a large sample from all the testing that you do and sequence them?
If I'm not wrong, but I think we have better experts than me at this panel, but I believe that either the WHO or the CDC is recommending about 5% of your positive cases should have some sequencing. So that should be a threshold that we should be aiming for.
Right. Okay, well, let me come back to Charlie Weller on that. I don't know if you want to add anything on the business of how we should be searching for variants. But I have another question too. But just on sequencing, what are we doing now, and how could we improve it?
It's such an important point that the virus doesn't kind of see borders. It doesn't kind of know whether it's the UK who's got a great sequencing and surveillance mechanism or Africa. What we need is a collaboration globally, and to build the capabilities and capacities around the world, so that, you know, in the UK we have got one of the best institutes, Sanger, for genomic sequencing, and this is why, or my view on why we identified the UK variant. It's not the UK variant, it's just that UK was able to identify it first. That's one of the reasons, because we've got this amazing surveillance system in place linked to the NHS. How do we speedily build this out so that other countries can build that capability, and we can have a connected mechanism for understanding what variants are circulating? Because if we don't know what's out there, we don't know how to respond. You know, we're always kind of a step behind the virus, and we want to get closer to being in step or even a step ahead.
Before we leave vaccines, 2 questions. We talked before this call, Charlie, about the sort of disparity between global supply and demand. And one of the slides showed that we're already coming up against the sort of short-term supply limits, in that all the manufacturers have sold out. And we heard this week that Pfizer is going to have to shrink output in its Belgian plant before it increases it again, because it has to sort of retool in order to increase capacity. But as a sort of truculent layperson, I look at this, and yes, 7.5 billion is a big number. That's the number of people on the planet, whatever. but it's more or less fixed. Yes, it's going up, but it's not going up as fast as the supply of vaccine, and that's going to go on going up fast, and more vaccines are going to be licensed. So I come back to my Pollyanna-ish view at the beginning. Is there not fundamentally a real ground for optimism that once the teething problems have been overcome, and I accept that they're an order of magnitude bigger in some less developed parts of the world, that actually vaccines can knock this thing on the head, so that, and this comes back to the overall theme of this session, so that we don't in fact have to adapt the way we live fundamentally?
Yeah. So there's a lot there. Firstly, around the timing of supply. There are different vaccine candidates coming through, and what the global network is trying to do is to have diversified, geographically diversified manufacturing, so that there is manufacturing across a different range of manufacturers, as well as, for example, the Serum Institute in India is stepping up, and it's one of the largest manufacturers around the world. So there can be transfer of the know-how from some of the large manufacturers to organizations like Serum Institute. So there's a way of scaling up quickly. And this is why we need more investment in not just more manufacturing of the current vaccines, but of different types of vaccines. And then there's the question you had about disparity across the world. And it's all very well that we in the UK and the US have got a great plan, and we're working towards vaccinating all adults in the UK. But what if then Malawi is or another country? I'm just randomly saying Malawi. It could be any other country who hasn't got such a robust plan in place, or a mechanism or a health system which will enable it. If the virus goes unchecked there and then mutates to a place where none of the current vaccines we have are effective, what happens then to even us in the UK, who we've managed to vaccinate everyone, for example? We're all going to be at risk of those future variants. So we do need to think about this as a global problem, and we need a global solution, not just to surveillance, but to how we fairly allocate the supply of vaccines, because there will be more demand than supply, especially this year. So how do we ensure that all countries have their healthcare workers vaccinated before, say, I'm vaccinated? I'm not in any risk group. I should be one of the last people to be vaccinated compared to people on the front line. And I think you had another question, but I'm afraid I didn't write it down.
Don't worry,
okay.
I've forgotten it as well. It can't have been that important, and I'm distracted. I'm going to come to Maurizio in a second about the hospital front line, as it were. But I'm intrigued, and this may relate to the question we've both forgotten, by what Lorraine is saying. Lorraine Mponella in the chat. I know it takes a bit longer to get to people in this format, but can you tell us about what you're concerned about in relation to undocumented people? Because that's clearly a category that is vulnerable. Can we find Lorraine? I haven't given you enough notice. I'm so sorry. Maybe we can come back to Lorraine. Yeah, we'll come back to Lorraine if we can. But in the meantime, let's come to Professor Ciccone and the front line. The point was made, it's something I read this morning, that even now there's a sort of cognitive dissonance between what people lucky enough like me and Charlie experience of this pandemic. We see news reports of ICUs, but we haven't been there as patients or practitioners. How are you, and one of your roles is as head of the European Society for Intensive Care Medicine, is that correct?
That's correct.
How are you learning to live with this? What are the main lessons that you've learned about how to treat people whom you first meet in a really seriously ill state?
So first of all, it's an important thing to say is that we've always treated patients with severe pneumonias in the intensive care. What COVID-19 has done is brought some light and put us under the spotlight. So I guess people have started to realize what we do in the intensive care. But viral pneumonia from flu or other chest infections has always been what we've done in the intensive care. So we had decades of research on how to treat patients in intensive care with pneumonia. And what we do in intensive care, just to remind everyone, is we call it organ support. It means that we use machines and techniques to support the organs when a patient cannot do it on his own or her own. And in practice, what we do, we buy time. We buy time so that the patient can do the fight with the immune system to fight the virus. Especially for COVID-19, we don't have a specific therapy yet. We had some great studies done in the last few months, in the last year, especially from the UK with the NHR. The recovery trial allowed us to understand that dexamethasone given to patients on oxygen can decrease.
Sorry, that's dexamethasone.
That's correct. Dexamethasone, which is an old drug, an old cheap drug, which we found when to use it, in which patient to use it, and that decreases mortality. For the rest, we are still looking for treatments. But the reality, what we do in intensive care is really supportive care. So we have very fine techniques to use our ventilators. You may have seen patients that are put with their on their belly. We call that proning. It's a way to bring blood to the parts of the lung that receive more oxygen so that we can oxygenate better the body. So we've always done that. The biggest challenge for us has been the volume of patient that comes at once. And there is probably being too much focus on devices and less focus on healthcare workers. You may remember I was in one of the epicenters in Lombardy during the first wave in March. People were talking, we don't have enough ventilators. The reality, we always managed to have machines, even if maybe they were not the best machines, but we always had machines. What is very difficult, however, is that every time you open an ICU bed, that bed requires competent people. And no one can find specialists just in a few weeks. So what we did in the majority of countries in the world was to stop some clinical activity that could be stopped, like we call that elective, like hip operations, orthopedic operations, so not cancers for which you will die, but something that you can put on hold. And we deployed these people to our intensive care units. Now, it was a very unifying moment, but also a very difficult moment, because you can imagine that you are doing one job one day, and the day after you're actually brought to an intensive care team. And that could be stressful for the workers that are deployed, but also for the intensive care team. So expanding ICU beds, I would say, should never be the first strategy. The first strategy should be containment of the infection in the community. Every time we have more ICU beds open, it means that we need more healthcare workers to come there. We need to train them. We need to help them to fit in our teams. But at the same time, it means that we are stopping some other activity. So there is being a lot of misinformation when people say, you're just focusing on COVID. Actually, we want to focus on every patient. But if we receive so many patients with COVID to our hospitals, then something has to stop to be able to guarantee cure and care for all the emergency services, whether this is COVID or a heart attack or some other emergencies.
What's the optimum patient-nurse ratio in ICU? I remember when we were in the UK talking about the Nightingales, there was people were saying we need 1-to-1 and we can only provide 1-to-6. What is adequate in your experience?
It's a great question, and also shows you that we have a variability of ICU beds in Europe. I worked in the UK. I was a consultant in St. George's Hospital, which is an hospital in London, for 14 years before moving to Italy again. There, our level 3 beds, which are the beds for the most complex patients, they work on a 1-to-1 nursing ratio. Remember that when we talk about 1-to-1, it just means that for any time point, you have always one nurse there. It does not mean how many nurses you need. You need to multiply that at least by 5 or 6, because we cover those beds 24/7. So that's just to give you a ratio for the UK. Probably every time you open 2 beds, you need 10 more nurses to come and work there. In Europe, it changes a bit. You go from 1-to-1 to roughly 1-to-2, 1-to-3. That is probably also a reflection of the number of ICU beds and intermediate care. Every patient that requires a breathing tube will go to the most complex beds, but intensive care varies a little bit in Europe. You may have something that we call high dependency units or intermediate care that in some countries is in intensive care, in some other countries is in other wards. But I would say roughly you can probably think something between 1 to 1 to 1 to 2, 1 to 3. So it's still a huge number of nurses and doctors and physiotherapists and other healthcare workers. It's a very large multidisciplinary team that you require to staff an ICU bed. So really every time you open 4 ICU beds, it's a lot of people that you have to bring to those beds. And it's not just the number, as I said, it's also the fact that it's very difficult to give the skills to those people, and you cannot do it in a few weeks. Indeed, one of the preparedness actions that we took with the European Commission between the first wave and the second wave was to create a course to train healthcare workers not working regularly in intensive care to give them some basic skills so that they could help in our intensive care team. We've trained something like 15,000 healthcare workers so far.
Oh, that's a big number. I'd be fascinated to know what the equivalent in the UK was and what we're doing about it now that we're no longer a part of those mechanisms. I'm conscious of...
Participated until December on this, and actually was a very active country.
The UK was?
Yeah.
Probably thanks to you.
But I would say also thanks to the UK members. And even if Brexit is on now, I have to say we have a very good relationship with our colleagues, scientific and clinical. I think that's an important thing to say.
Well, long may that continue. Thank you. As I say, time is marching on, and we're going to come back to Lorraine and to Anthony Cope, who's been busy in the chat. But first, I wanted to come back to Professor Dingwall and back out onto the streets, if you like. Professor Dingwall, I want to quote you, and forgive me, because we all know how the media works, and it can be taken out of context. But you've called this is really in relation to vaccines and getting back to normal. You've said that they are a game changer. In a vaccinated population, COVID will mostly mean a few days off work and will very rarely result in serious illness. Are you optimistic that a year hence, life will look much more like life at the end of 2019 than it does now and than many people fear?
Well, my optimism is qualified really by what I would say is the social and political obstacles to achieving that. I have every sympathy for our colleague who's been working in intensive care, and for some of the comments about long COVID in the chat. But I think we need to be really clear that intensive care is not the typical experience of COVID. That and I really want the participants here to disregard all the pictures they've seen on the BBC News at 10 for the last couple of weeks. There is a particular crisis, short term. It is very much a capacity crisis in our health service, resulting from our decisions to run that service with hospitals at nearly 100% capacity most of the time, whereas most of our European partners have typically around 20-25% of beds empty. So there's a more inherent resilience in the systems than we have in the UK. I don't want to dwell on that, but I do want to get the message across that we need to think in a post-vaccine world, what restrictions are proportionate to an infection that already has a fatality rate of less than 1%, possibly as low as 0.2%, although that's contested. But we're looking at something which has a very low risk of mortality. Where that risk is falling all the time as the vaccines roll out among the highest risk groups. Sorry, Giles, you want to come in?
I always wonder when the conversation turns to fatality rate, and again, this is as a layperson, there is a relatively low fatality rate, surely, as a result of the extremely stringent measures that are already in place to try and keep it under control. Isn't that the case? But for the lockdown, the fourth lockdown that we're already going through, would it not be much higher?
Well, no, we're talking about an infection fatality rate. This is the risk of dying if you get infected. So that's not affected by the control measures. The control measures are to some extent protecting the most vulnerable groups, and they probably are suppressing it a bit. I mean, when the infection first emerged in Wuhan, people were looking at an infection fatality rate of about 3.5%, because the only cases that were being identified were the ones that required hospitalization and were seriously ill, because at the beginning, nobody had any real conception of how many asymptomatic and mild cases there were out in the community. Although WHO did identify that very quickly, that this was something like 80% of the cases. But I mean, with the improvements in treatment that Maurizio has talked about, particularly the introduction of dexamethasone, and even more with the introduction of the vaccines, if we accept the clinical trial data, what they are doing is having a major impact on mitigation, so that the people who get vaccinated do not get as sick, and the likelihood of their requiring hospitalization or dying falls very rapidly. So we are looking at, so we're then sort of saying, well, really with the question that the Chief Medical Officer in the UK has been asking is not about eliminating this vaccine, but deciding what is a tolerable level, what is a tolerable infection fatality rate. And we're going to get somewhere close, I think, to that of influenza, which is around 0.2, 0.3%, fairly quickly. And we've lived with that for 50,000 years or so. Why would we necessarily change? And that raises then the question about what other restrictions are proportionate to a post-vaccine world where the typical experience of COVID, and I stress that, is comparable to that of other long-established respiratory infections. We do not shut society down for the other coronaviruses that contribute to the common cold. We do not shut it down for seasonal influenza. If we were faced with a viral shift that resulted in a pandemic influenza strain, we have the technology, as Charlie was saying, to produce a new vaccine for that very quickly. And any restrictive measures would be in place for a determinate and fairly short period. And I think one of the challenges that I would put to Charlie and her colleagues is, how do we get to a comparable state of knowledge about coronaviruses for when we deal with the next crossover from an animal to a human population, so that we can move as quickly in those circumstances?
Well, I really do.
I want to say one more thing.
Yes,
no, Giles, come in.
No.
This is the monologue.
Well, we are short of time, and I would like to hear their views on that. I promised to come to Lorraine on a whole category of people who may fear they'll never get a vaccine. Lorraine, can we come to you?
Hello, can you hear me?
Yes.
Okay. Yeah, so my name is Lorraine. I'm an asylum seeker. I'm joining from Coventry. In Coventry, I'm part of a group called Coventry Asylum and Refugee Action Group, in short, CALAG. So my question was around, NHS is sending letters to certain cohorts of people, like elderly people. So what about people who are not registered with the NHS? How are they going to know that now is their turn to get a vaccine? And if at all there'll be a chance for that? And people are not registered with the NHS because of fear that maybe they might be reported or they will be deported, and therefore they just stay. And we know that some of these people are frontline workers. So how can we control the virus when we are leaving other people outside of the vaccine program?
It's a good question, Lorraine. I'll put it to Charlie if she knows. But just before we leave you, you personally, do you understand, as an asylum seeker, what is your status in relation to the vaccination program in the UK? Have you been offered one? Do you know if you will be?
Not yet. No. Maybe because they've not come to my cohort. I'm not sure, but yeah, not yet.
Okay. Charlie or Robert or anybody, do you know what the policy is in relation to undocumented people, and frankly, globally as well? Of course, there are very large numbers of people in the US and elsewhere who would fall into that category.
Robert, I think you had your hand up. Go for it.
Well, yes. I mean, I'm a member of the JCVI group that's looking at precisely this issue, Lorraine, and I don't think it's stretching the confidentiality of our discussions too much to say that a specific program is under discussion, directed at the groups that you're describing and various other groups who are unlikely to be listed by the NHS. I mean, the criterion for vaccine eligibility in the UK is living in the UK. It's not being known to the NHS at this point. And there will be specific outreach programs to groups, undocumented groups like travellers, homeless people, people living on the street. But these will be in addition to and in parallel with the mainstream program of writing to everybody who the NHS knows about in an orderly queue to invite them to come forward. But there's no question at all about omitting groups like those you're speaking for, because the important, the vulnerability of those groups is well recognised.
Thank you, Robert. And Lorraine, I hope that gives you some sort of consolation.
My fear, I think, is the same, to say, where will people get now that courage to say, yes, I'm going? How are these organizations or these outreach programs going to make sure that these people not be reported? Because that is the issue, that once, you are reported, therefore, you'll be prone to deportation. So I'm just thinking in terms of how are the issue is how these outreach programs will make sure that these people are not being reported.
To be honest, Lorraine, I don't think anybody can give you an absolute guarantee about that. But the plan is for local government, for this to, as I understand it, it will involve local government interacting with local groups of the kind that you're representing, to discuss how the program could be delivered in a way that would bring the confidence of those groups. And while the Home Office is always likely to do things on its own, I don't think there is any intention within the public health system, to carry this out in a way that makes people vulnerable to deportation.
Okay, thank you. It's a huge subject. Lorraine, Robert, I'm glad we've actually been able to bring some expertise to bear, but it is a subject for a whole nother hour. Anthony, there is another category of people who are already finding out what it's like to live with COVID, and that's people with long COVID. And you wanted to say something about that.
Yeah, basically I had a bad cold at the beginning of the pandemic, and because at that time there was no test for COVID, I didn't think I'd got COVID. I just thought it was a bad cold. But ever since then, I've had stomach problems, which is part of the COVID scenario. And I've got a rash down the back of my legs, which I've never had before in my life, which is something that you get after a very bad viral infection. And it has been now diagnosed as what they call baculitis, which is not very nice at all. And the fatigue that I'm getting, incredible. I literally have to go and have a lie down at least twice a day. So then that's knocking on to things like work and stuff like that. And this is just the after effect of a mild dose of the COVID. I mean, for people that have been in intensive care, my God, I cannot, I can only guess at what they're going through. But it's bad enough even when you've had a mild dose of it.
Right. Thank you, Anthony. I mean, I think one thing that indicates how little we know for sure about long COVID at the moment is that it may be that people who have mild initial infections suffer most from long COVID. And as the slide showed, 186,000 people in the UK alone are suffering from that. We are nearly out of time because these are only 45-minute sessions. But I want to give all our speakers a chance to sort of round up. Let me come first back to you, Maurizio. And by all means, pick up on the long COVID point if you've encountered that. But more generally, I wanted to ask, do you see light at the end of the tunnel? And how long is the tunnel that you're in?
So first of all, I think we need to reassure people that we know better this virus. We have some treatments. We know what works, what does not work. But at the same time, we have to tell everyone, that if you look at half of the patients in our intensive care unit are below the age of 60, 62, this can still affect everyone. And while the individual risk is probably low for everyone, the society, for something that is so transmissible, can see a lot of patients still coming sick to our hospital. So I think as a society, the light at the end of the tunnel comes through individual responsibility, adhering to the usual measure, distancing, face mask, hand hygiene, outdoor spaces if we can. And of course, the vaccination, I think, is the duty of all of us, if we're offered a vaccine, to take it. And this ultimately is what's going to come to an end with this crisis. But until we vaccinate a very large percentage of the population, we have to learn to protect each other and to adhere to these measures.
Right. Thank you. Nice segue. Robert, let me come back to you. We have to learn to protect each other. A year from now, how many of the public health measures, habits that we've been encouraged to adopt, do you think we will still be using? I mean, let me put it this way. Will football stadiums be full again? And will we ever take off face masks on public transport?
Well, the only reason we wouldn't do it is an excessive caution and risk aversion in the society as a result of the levels of anxiety and fear that people have been driven to from various sources over the last 12 months. I mean, in practice, we could get there a lot quicker with a more determined effort by government. And I think the explicit abandonment of this false god of elimination. I mean, to my mind, the one thing that is worth keeping indefinitely is washing our hands a bit more. I mean, the Brits are really bad at that, and it would actually protect us against quite a lot of other infections. If I don't wish to speak for colleagues, but I mean, the number of people that one sees using public toilets and walking straight out again is really quite shocking. And World War II did provoke quite a change in habits. That sort of tailed off in the 1950s, 1960s, and that's worth reinvigorating. Face masks have added very little. I mean, there's really no convincing evidence of benefit anywhere, particularly in outdoor circumstances. Football stadiums could even now be a lot fuller than they are. The bottleneck is actually the passages through to the seating areas. I think it is very hard to see an evidence-based scenario for continuing most of the restrictions that we're seeing much past the late spring, early summer. But I think in terms of the sociology and the psychology, it would not surprise me to see them last a good bit longer, whether we think they're necessary or not. Over.
Okay, thank you. Charlie, let me give you the last word. I know your specialism is vaccinations rather than public health more broadly, but do you share that optimism? And I wanted to squeeze in one other question. What early warning system does the planet need for the next pandemic? Let's just assume that we get this one under control, and we've returned to a less restrictive sort of life. What happens when we hear about a new SARS-like outbreak in, say, Malawi or Iran or Oklahoma? What needs to happen then to stop it taking over as it has?
Sorry, I was on mute. Can you hear me?
Yeah.
It's a great question, and I think it's kind of what Robert was alluding to earlier. We need to learn so much from this experience, from COVID. There is a huge amount we still need to learn. There's so many research questions out there around long COVID is just one example. So thank you, Anthony, for sharing that with everyone. But as for an early warning system, what we need in place, we need preparedness, and that comes in many different formats. It really does need a holistic approach. It's great having preparedness in the form of CEPI for vaccines. We need an equivalent for diagnostics and therapeutics, because it's quite probable that the next outbreak, the next epidemics, the next pandemic will be something else we haven't prepared for. So how do we prepare effectively for disease X or the unknown? And we can learn a lot, because essentially that's what COVID has been. It's been a new virus that we didn't necessarily expect. I think we would expected the next pandemic to be flu, to be honest. And so what have we learned? What went well? The speed of vaccine development has gone well, but that was because we had mechanisms in place globally. But I think above all else, we need to know what's out there. We need to detect. We need that surveillance in place. And we need to treat this as a global problem. It is going to come again. And therefore, we need that global solution where we are working together. So strong leadership is needed, the governance, and then the technology behind that as well. And what this comes down to is investment, long-term investment in those surveillance mechanisms, in the preparedness mechanisms.
Thank you so much. Well, we've gone 6 minutes over. I want, in relation to this session, first of all, to thank Maurizio, Charlie, and Robert for joining us, Anthony, Lorraine, and everybody else for pitching in. I think it's been a really interesting discussion. I've written down and underlined Robert's line about the false god of elimination, essentially saying, let's not let perfection or be the enemy of practical steps to return to something like normal. My overall impression is we'd better get used to the idea that the new normal isn't going to be like the last, but that vaccines do give us a shot at everything that has been claimed for them. As Charlie and Maurizio, I think, agreed, and I think we all do, we've obviously got to get better at identifying variants of this viruses and the next crossover viruses really, really quickly and responding really, really quickly. And on behalf of everybody who's taken part in all 6 sessions, thank you so much. Thank you to Scottish Widows, our partner. I need to say that all the 5-slide guides, or SenseMaker guides, as we call them now, that have been prepared for each of these sessions are available to view at your leisure on the Tortoise website. My colleague Merapi Mills will be doing a readout of the whole day, so that to give an idea of what we think are the highlights and things that we're going to pursue further. I'm going to plug my own next Tortoise Thinking, which is tomorrow lunchtime, when actually we will be talking in more detail about vaccines and mortality and hospitalizations. If anybody felt that they wanted to get a word in edgeways and were unable to on that, please join us at 1 o'clock tomorrow. And finally, I've been asked to say that we're not going to shut this down even now. Tortoise people and everybody else, if you have time, are invited to stay on the call for 15-20 minutes, when we will proceed immediately to a sort of editorial wash-up to have an initial stab at what we at Tortoise, what has stood out from the day's discussions and what we want to pursue further. There is no pressure. I quite understand that most people have other things to do. So again, final thanks to all our guest speakers, especially the 3 who joined us this hour, Professor Robert Dingwall, Dr. Charlie Weller, and Dr. Maurizio Cecchino, excuse me. Thank you very much. And anybody who wants to stay on for the wash up, please do. Thanks a lot.